Good afternoon, everyone. This is John DeStefano from the New England QIN-QIO, and I'll be your moderator for today's webinar, Moving from Volume to Value, a provider's perspective on preparing for payment reform. The New England Quality and Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be muted for the duration of the presentation. Please enter any questions in the chat box and we'll address them at the end of the presentation. At this time, I'd like to introduce today's speaker, Dr. Dale Bratzler. Dr. Bratzler has worked in the field of healthcare quality, measurement, and improvement for many years. He is a professor and associate dean at the University of Oklahoma Health Sciences Center. He also serves as the Chief Quality Officer of OU Physicians and is the Medical Director of the Clinical Skills Education and Testing Center at the University of Oklahoma. Please welcome Dr. Bratzler.
Thank you, John. It's really a pleasure to be here, and I really enjoyed the opportunity to get to speak to you guys this afternoon, and I always think I'm lucky to get to talk about this topic of moving from volume to value because I always learn so much from the questions that you ask. Let me briefly go over the outline of my presentation for today. Okay. So here's the outline that I'd like to cover today. The first point I'm going to make is that I think payment reform was inevitable in the United States. And if you'll indulge me, I'm going to go through a short number of slides just to highlight that point, and we'll go through that very quickly. Then I want to spend a little bit of time talking about some of the changing models of healthcare payment and the importance of doing ongoing performance measurement, particularly in an ambulatory care setting. And then finally, I'm going to talk about some of the things that we've been doing and things that I think are important in preparing a practice for promotion of the health of the population and being prepared for value-based payment going forward. Now, let me just briefly mention that I'm working at a very large academic center. We have about 900 providers in our group, which includes all of our physicians, advanced practice nurses, physician associates, and we have about 68 different clinic sites. But I continue to work with a large number of small providers around Oklahoma in particular as they start to think about how to move to value as a part of several contracts that I work with in the College of Public Health. So, why was health payment reform inevitable? And this is the most up-to-date information from the Commonwealth Fund that simply shows, as many of you already know, the United States spends an enormous amount of money on health care, more than twice that of any other industrialized nation in the world. And even though healthcare costs have started to stabilize a little bit, they've also stabilized in other countries, and we still have this very large gap between the amount of spending that we do on healthcare as compared to other industrialized nations. And that comes with not a lot to show for it. So this particular slide from Commonwealth also highlights how the United States ranks as compared to other industrialized nations with respect to a whole variety of quality of care, access, efficiency, other outcomes. And when you compare it to these nations, the United States, though we spend about twice as much on health care, ranks last as compared to other industrialized nations. And in fact, there have been many, many, many studies that have published that have been looking at a whole host of population health metrics, quality metrics, and others, and show that the United States does not rank particularly good on quality. This is one of my favorite slides, just looking at healthcare spending versus average life expectancy. And again, we don't have the longest life expectancy in this country, and yet we spend a lot more money on healthcare in this country. So we spend a lot on healthcare. No surprise to any of you, and certainly has been the topic of many conversations in the lay press and also with our legislatures. So the other problem I think that most of you are aware of is that you've had a payment system that historically rewarded more care regardless of the value or the quality of that care. You can pretty much order any test once you're in practice without regard to whether it's necessary, whether it will actually be used to improve patient care, whether it's going to subject the patient to additional testing that may be unnecessary. And we've had payment models that really have not promoted coordination of care across settings. So very commonly in our setting here in an academic center, we see tests that get repeatedly done because patients come in from multiple settings, and there's just not good coordination of care across those settings. And so tests are repeated, procedures are repeated, and other things. The other point that I'll make is that when we do testing procedures, none of them are risk-free, and in fact, sometimes they cause patient harm. I was sharing this with our students in the College of Public Health in class about 2 weeks ago, and I just pulled up this particular paper that looked at CT scans, highlighting that people forget that when you do a CT scan on a patient, that's the equivalent of 74 mammograms of radiation or 440 chest x-rays. Now, if you're my age, maybe that's not a big deal, but in kids, doing unnecessary CT scans has the potential to expose those patients to unnecessary risk for the future of development of malignancies. And there are many, many, many other examples we could show in healthcare where unnecessary testing or other things leads to a whole litany of other tests that may be done that result in additional care for the patient that may or may not be useful. I think another point that was really driving payment reform has been consumer groups. So they really have been focused on and demanding transparency, both about quality of care, but also about cost of care. I'm not going to spend a lot of time talking about transparency, but as you know, the Medicare program now releases all payment information for physicians. Many different organizations now are starting to look at transparency of costs. Some providers have embraced this and started publishing their prices online. And as you know, there are a host of websites now that you can go to look up the quality of care for a variety of providers. So consumers have been demanding it, and I think consumer voices have really been one of the key drivers of what Congress has done. So when these consumer groups have had consistent messaging, legislators respond. I even saw that within our own state when consumer groups went to our state legislature and started demanding the reporting of health outcomes such as healthcare-associated infections across the board for all hospitals in the state. Legislators respond when consumer groups come up with a plan. So Congress has legislated much of the changes in both transparency, quality reporting, and payment reform that we see going forward. And since 2003, Congress has passed multiple bills that have required a variety of different healthcare providers to start collecting data on their quality of care, transmitting it to the federal government, having it openly available in public domain, and tying some form of payment to that quality data. What happened early on was that the data was used to incentivize, the payments were used to incentivize reporting of quality data. Now, as you all know, here in the hospital setting or other settings of care, the actual quality of care that you're delivering now impacts your payment through a variety of different payment programs, and we'll touch on a few of those just very briefly. So to kind of summarize my first bullet point on healthcare transformation, payment reform was inevitable. I think there was this growing recognition in the United States that we truly had the best sick care system in the world. You know, when somebody's really sick, has a bad disease, a bad malignancy, certainly you want to receive care in the United States because we're really good at it. We're good at high-tech stuff, complex care. We're very heavily hospital and specialty-based, and it costs a lot of money. What we don't do very well is keep our population of patients healthy. We wait until patients get sick. We wait until patients call for appointments. We don't have a good system in this country of ensuring that the majority of the population is healthy, and I think we pay for it then at the back end through our high-cost but very good sick care system. So the Affordable Care Act passed in 2010, signed by the President, and I'm not going to talk about the Affordable Care Act because there obviously are parts of it that are quite controversial, but one thing that the Affordable Care Act clearly did was really accelerate the move to value, which has been defined as quality and service divided by cost of care. And the goal is simply that we want the highest quality of care and service at the lowest cost available. The other thing that the Affordable Care Act really drove was innovation, providing funding to the Centers for Medicare and Medicaid Services and also CMMI to do a bunch of different demonstrations to see how they could start changing the payment models, to see if they could reduce costs and improve quality of care. And the other thing that the Affordable Care Act did very well was promote transparency about both costs and quality of care. So transparency is here to stay. I tell the first-year medical students when I lecture to their class that literally data on their quality of care, the cost of care that they deliver, is going to be in the public domain for the rest of their career. They might as well just simply be used to it. Transparency around quality and cost of care are not going away. Now, I will be the first to admit that there's such a proliferation of different reports and rating systems that some are not consistent with one another that I think it's confusing to consumers. But I actually think health administrators do pay attention to these reports because no one wants their particular system or hospital or nursing home or dialysis unit to look bad in the public domain. So let's talk just briefly then about some of the changing healthcare models for payment. And I love this slide because I think in one slide it summarizes really this fairly dramatic shift in payment that's ongoing in the United States and maybe happening faster than we thought it might. So back in 2003, when Congress started passing laws that required hospitals first to start reporting quality data, they tied incentive payments to that reporting. So the Medicare Modernization Act was passed, and it said basically a portion of a hospital's payment would be withheld unless the hospital collected, submitted for public reporting quality data. So this was just payment for reporting. We then moved to the model, the value-based purchasing model, where there were incremental fee-for-service payments for value, which is essentially what happened in the hospital setting now under the value-based purchasing program. Hospitals report data. If they don't, they obviously see cuts in pay for not reporting. But then that score, the score that's calculated, is used to actually adjust payment. And as you know, in the hospital setting now, we have programs like the Healthcare Associated Condition Program, the Readmissions Reduction Program, and the Value-Based Purchasing Program. And all three of these programs actually adjust hospital payment based on the quality of care that's being delivered based on these reports that are being captured. Another thing that I'll mention briefly here in just a moment is this concept of bundled payments for an acute episode. So CMS now has implemented numerous demonstration projects around the country on bundled payment programs, the concept being that a lump sum payment is made for a service like hip replacement or cardiac surgery. Perhaps the payment's made to the hospital, but then the hospital pays the individual practitioners that provide care. There's no incentive under a bundled payment program to do more tests, to do more procedures, to keep the patient in the hospital longer, to use the most expensive prosthetic device. the actual profit margin is driven more by providing high-quality care because you have to meet the quality metrics, but also by reducing total cost of care. And there are bundle payment programs now for chronic care and disease carve-outs. There are a whole host of them. If you go to the CMS website or CMMI website, you can look up a large number of these bundled payment programs for a whole variety of chronic conditions also that CMS has been testing to see if this concept of paying a single payment for a bundle of services reduces overall cost of care and drives improvement in quality. And then to the far right, where I think a lot of people think we need to get to, and that's the concept of accountability for population health. The concept that you get some form of payment at the health system level, whether it be at a community level. There's the new model of the community care organizations. And the goal here is to keep the population healthy. Again, you don't benefit, you don't gain extra payment because patients go into the hospital or need tests or procedures. Obviously, provide that when it's necessary, but it starts changing the way you think about delivering health care to start thinking about how we actually keep our population of patients healthy. So the important thing about this slide is that there is increasing risk assumed by the provider, but also increasing coordination and integration of care required as you move from the left to the right. And again, the payment then model changes from getting paid more for doing more to profiting by keeping your population of patients healthy, delivering high-quality care, and doing so at the lowest possible cost. And CMS has really embraced this. You may have seen the article that was in the New England Journal of Medicine published by Sylvia Burwell, the Secretary of HHS, that basically said by 2018, CMS hopes to have 50% of all Medicare payments going through some alternate payment models, and at least 90% of all Medicare payments where at least the payment is tied in some way to the quality of care that's delivered. So CMS has made this commitment to rapidly shift the way that they pay for health care and to essentially tie payment to either quality metrics or payment to alternate payment models. So again, I think it's accelerating a lot faster than a lot of people thought. I'm just going to go through a series of 4 or 5 slides here just to show you that I've put the website on all of these slides so you can go look at these yourself. But again, there are numerous bundled payment initiatives that CMS has already implemented all over the country. Go to this website and you can see the long list of conditions that they've developed bundled payment programs for. Again, bundled payment is one of the models that's felt like it will have substantial impacts on overall cost of care. The most recent bundled payment program that got a lot of press lately is the comprehensive care for joint replacement model, where essentially payment for hospitals will be tied to overall cost of care. Again, you have to meet quality metrics, but if you spend more than is expected for your marketplace, then the hospital may have to repay some of the payment they received from the bundled payment program. And importantly here, this is mandatory. So I happen to live in a community that was not in a bundled payment program for joint replacement, and we are now. It started April 1st, and it is mandatory. There was no opting out of this particular program. So again, CMS pushing this forward as a mandatory program. Transforming Clinical Practice Initiative. If you haven't heard about this, this is a program that had large funding, more than $300 million, to actually go out and work with about 140,000 clinician practices across the country to try to prepare the practices for value-based payment models for the future. Really, a lot of this money, I think, will be targeted to smaller practices that don't have a lot of infrastructure to think about promoting care coordination between providers, establishing community-based teams to support chronic care management and other things. So you may have heard about this program, and if you have the opportunity and you're not involved in any current models, I would encourage you to think about participating in the Transforming Clinical Practice Initiative. One for cancer care that's just been announced on oncology care model, developing new payment and delivery systems, particularly focused on patients who are receiving chemotherapy. Again, a very, very high-cost item in the Medicare program, and trying to do better coordination of care to reduce overall costs and to coordinate that care better. Comprehensive Primary Care Plus, the one that was most recently announced. If you haven't seen this, you might want to take a look at this because the Comprehensive Primary Care Plus program is a national advanced primary care medical home model which is looking at changing the way that healthcare providers, clinicians are paid, particularly primary care physicians, to drive quality and reduce cost. I think their goal is to enroll about 20,000 primary care physicians in this initiative. This was just announced within the past week or so. So those are just some websites you can go take a look at just to show that I think CMS, the Secretary of HHS, are really committed to moving Medicare payment at the very least from volume to value. Well, what about the legislature then? So as I think probably everybody knows, we have a presidential election going right now, and there's a lot of rhetoric about what will happen to the Affordable Care Act if the administration changes. So in other words, if we have a different president or a different party, will these payment models go away? Can doctors assume that they won't have to worry about these changing payment models? And I think the answer to that question is no. And all you have to do is look at the Medicare Access and CHIP Reauthorization Act, or MACRA, the bill that physician groups all over the country praised because it repealed the sustainable growth rate formula for physicians. But I just wanted to highlight a couple of things about that bill. First, the sponsor for the bill was a physician, Michael Burgess, from Texas, a Republican. And this bill passed the Republican Senate and House by overwhelming margins. In other words, it was very, very bipartisan, one of the most bipartisan votes that Congress had in quite some time. Look at the Senate and House votes for the bill. But what a lot of doctors, I don't think, recognized, at least early on, about MACRA, everybody was excited that it repealed the sustainable growth rate formula, but it has all sorts of provisions in the bill that are going to drive physician practices to either measure quality and have their payment adjusted based on quality, or drive them into alternate payment models going forward. So a lot of physicians are happy that the PQRS program, value-based modifier, and the meaningful use program are sunset at the end of 2018, and they're replaced, though, with a program called the Merit-Based Incentive Payment System, or MIPS, in 2019. Now, just for your information, recognize the first performance year of data for MIPS will be care that you deliver in calendar year 2017. There's always a 2-year lag between the performance data year and the year that CMS uses to adjust your payment. The bill created strong incentives for physician practices to go into alternate payment models, including accountable care organizations, advanced medical homes, bundled payment arrangements, or others that may be developed by CMMI. And there are financial incentives for physician practices to participate in alternate payment models. And the other incentive is that if you have a defined amount of your Medicare payment coming under one of the incentive programs, one of these alternate payment models, then you don't have to participate in the MIPS, the Merit-Based Incentive Payment System assessment. What we don't know yet is what are going to be the, quote, approved alternate payment models. That still remains to be defined. So, as an eligible professional in 2019, you will either go down the pathway of being a part of the alternate payment mechanisms or the Merit-Based Incentive Payment System. And you will have to have a substantial proportion of your revenues come from an approved alternate payment model, again, to be defined. 25% of your Medicare payments in 2019 must come from an alternate payment model to go down this pathway, 50% by 2021 and 75% by 2023. If you can't meet that, currently in Oklahoma, we haven't had a lot of alternate payment model mechanisms available, and so then you would have to participate in the merit-based incentive payment system. Each provider will get a score, 0 to 100, and you will either receive incentive payments or penalties based on your score. If your score is below the national median, you will see a payment penalty. If your score is above the national median, you will see payment incentives. Well, what does this program look like? Well, MIP scoring, it looks very similar to programs you're already familiar with. 25 of the 100 points will come from meeting certain meaningful use objectives. 30 points will come from the metrics that are used for PQRS and the value modifier. 30 points will come for the resource use portion of the value modifier metrics, efficiency of care, and 15 points for doing clinical practice improvement activities. So you'll go down one pathway or another. I'm not going to review this slide, but I put it in just so you can see some of the clinical practice improvement activities that might count under the MIPS program. So you would have to be able to demonstrate that you were doing some of these things to meet that clinical practice improvement initiative to get those 15 points as a part of the MIPS score. And essentially, the score, if you're under MIPS, there'll be a threshold established by CMS every year. If you're at the threshold, you'll see no payment adjustment. If you're above the threshold, you'll see an additional incentive. If you're below it, you'll see penalties. Those penalties range from 4% in 2018 and 5% in 2019, all the way up to 9% in 2021 and 2023. So, and again, the other point I always make about the MIPS program is there's no one standard deviation buffer as is currently built into the value modifiers. You're below the line, you see the penalties. If you're above the line, you can see some incentives. The program must be budget neutral. Therefore, to have winners, you have to have losers in the program. Well, let's say you don't want to do MIPS, and so you decide you're going to focus on the alternate payment model route, and maybe you decide to become an advanced patient-centered medical home, and maybe participate in some bundled payment agreements or a local ACO. Does that mean you get out of all the quality reporting that you have to do? Well, the answer is no. I simply highlight that if you, let's say you're participating in an accountable care organization, those models require that performance metrics be captured and reported. In fact, currently, there are 33 performance measures in 4 key domains that have to be reported by an ACO before you can share in any of the payment incentives that come with being in these programs. So, long story short, quality measurement, quality reporting, I think, is here to stay. It doesn't matter whether you're going the alternate payment model route or the MIPS route. Capturing data and reporting it is going to be part of the program. The other point I'll simply make is that it's not just Medicare. Major providers, insurers are also pushing payment models. This group, this collaborative of large organizations, basically said that they wanted to shift 75% of their business to contracts with incentives for quality and lower healthcare costs by the year 2020. Well, remember, the Affordable Care Act required by law that CMS start reporting and using the value modifier to adjust all Medicare payments beginning in 2017, regardless of the practice size. If you are in practice and you receive Medicare payment, you are subject to the value modifier beginning in 2017. Starting in 2015, large group practices had to have their payment adjusted based on the value modifier. Then it went down to 10 physician groups, 2016, 2017 by law. Anyone that bills Medicare is subject to the value modifier. Virtually all Medicare Advantage plans already hold providers accountable for the quality of care, and many of them have payment incentive programs to deliver high-quality care. And again, I meet routinely now with a host of private payers, in our practice, Aetna, Blue Cross Blue Shield, Humana, United Healthcare, and all of them have programs in some way, shape, or form that reward quality and efficiency. So this is being broadly adopted nationally for changes to the payment models. You're all familiar with PQRS program, currently for 2016 reporting. If you don't report, you'll see a 2% reduction automatically in your Medicare payment across the board for everything you do, inpatient, outpatient, or any setting of care. Similarly, the law then requires that CMS, remember this is part of the Affordable Care Act, calculate something called the Physician Medicare Value Modifier, and CMS essentially calculates a quality composite score and a cost composite score. They use that, roll it together, and create a value modifier amount, a score. And if your score is above one standard deviation outside of the mean, either for cost or quality, you can see either payment penalties or payment incentives. So what does that look like? Well, very importantly, for last year, for 2015, and 2016. Remember, I already said, if you don't report PQRS measures as a practice, you will see an automatic 2% across the board cut in your Medicare payment. But CMS has also taken the position that if you didn't report your PQRS measures, they can't calculate the value modifier for your practice. And so 6% of your payment is tied to whether or not you submit PQRS measures. This 4% then can be modified based on the overall quality of care. And oh, by the way, if you don't happen to participate in meaningful use, 9% of a physician's total Medicare payment in 2017 is tied to performance on PQRS measures, meaningful use, and the value modifier for care provided in 2015. Remember, there's always a 2-year lag between the performance year and the actual payment adjustment that occurs. So substantial amounts of physician payment are tied to these programs. And again, you could argue that the macro bill passed this past year sunsets all of these programs, but when you really look at it, those programs get rolled up into the MIPS program, or you have to be in alternate payment models going forward. One report, if you've never seen it, I'm going to show you, just the high-level report for our practice, but it's the Quality and Resource Use Report. The Affordable Care Act requires CMS to create a physician report card and provide them data on both their cost of care and quality of care. Also, when they upload this data to the CMS portal, you can also download the patient-level files and see which of your patients are being hospitalized, how much it's costing. So it's really very useful data that is provided at the physician practice level. So it's called the Quality and Resource Use Report. If you've never seen it, I would strongly encourage you to look at it. I lectured at an internal medicine conference a few weeks ago, and I was actually fairly surprised by the number of practices that had never gone to the CMS portal and pulled down their report. Again, if you were a larger practice, you should have a report on the CMS portal. This is what the high-level report looks like. It calculates your cost and quality. Essentially, every dot represents a practice of 10 or more physicians in the country. The red dot happens to be us. Where you would like to be is in this upper right quadrant, because practices over here in this far upper right quadrant see payment incentives. But these practices down here, low quality, high cost, will see payment penalties. Our practice has been working on this hard. We're on the positive side on quality, but we're actually right at the national average on cost, and something that we're really taking seriously now. The other point I'll make is that your patient satisfaction data, CG CAPS data or PQRS CAPS data, is also being rolled into this report on your quality and cost of care. And again, the payment incentives, if you're one standard deviation beyond the mean, so one standard deviation above in terms of quality and cost, low cost, you can see a 4% increase in your payment. You can see a 4% cut in payment if you were high cost, low quality. So this is how the value modifier already affects physician payments currently for physician groups of 10 or more eligible professions. So let me end by talking about how can you get ready for this change, this move from volume to value. And this is just my thoughts, things that we've been trying, but I just wanted to highlight a few things that I think you can do. One is use the resources that are provided. So for instance, if you're a physician practice of more than 10 providers and you've never seen your QIn-QIO, go look for it, pull it down from the CMS portal, start studying it. It provides all sorts of data. It's a multi-page report that shows you quality metrics that CMS calculates for you based on the claims data from your practice. It reports your hospital readmission rates, total cost of care for a variety of conditions, and an important measure that's called the Medicare spending per beneficiary for your practice. So it really starts to provide you with actual data on your cost of care and quality of care. The second thing, I strongly recommend that you measure quality within your practice and start keeping track of those. And frankly, what we have done, and I think most people are doing, it's smart to focus on those metrics that are likely to drive your value-based contracting payments. We've decided to be very transparent with our data, both physician satisfaction data in terms of our patient satisfaction data, but also internally with our quality reports. And then the other thing is we've spent a lot of time training our staff to understand these changes that are coming, because what we're trying to highlight is that this can't be business as usual. We have to start changing the way that we deliver care for our patients. So we measure quality. We create all sorts of reports. This is our Influenza Report. When I first took over the position of Chief Quality Officer in 2012, we couldn't document influenza vaccination on the majority of our patients, mainly because it wasn't documented anywhere in the chart. We did some simple steps, created EMR templates, created some central influenza immunization clinics in our major practices, and have driven rates. But what we're trying to do is make this transparent. We show this to everybody within the practice, and we set performance goals for both staff and for our employed physicians based on some of these performance metrics. I would encourage you to go to this website, the Core Quality Measure Collaborative. It was led by both CMS and America's Health Insurance Plans. It gives you a list of metrics that they have recommended to be the core metrics that you would be held accountable for. And so we're using this list to kind of guide the things that we're focused on within our own practice, because these are the things that we think we're going to be held accountable for in the future. So we're making sure that I can measure these, that I have reports that actually generate that. We use the QIn-QIO we get the report twice a year. You get a mid-year report and the end-of-year report. This is our first report in 2012. We've been working hard to move our dots. And the reason is we know that eventually this is going to be tied to the value modifier payment or the MIPS program, either one. We want to be able to show that we're delivering high-quality care. So we use this report. We're looking at cost of care to try to figure out how we can start being more efficient in our practice. And we're actually taking the patient-level files that are uploaded with the QIn-QIO and really starting to explore those patients. One of the things we find in our practice, by the way, is that about 20% of the patients that CMS attributes to our practice are only being seen by our specialists. They're not being seen by our primary care physicians at all. And so what that tells me is that we have to identify those patients who don't have primary care physicians and make sure that our specialty physicians are addressing some of their primary care needs and addressing these quality metrics that we're being held accountable for as a practice. We use this report. We use it a lot. We're completely transparent internally. I've taken the names of the doctor's offices of one of our family medicine clinics. Each of us would have been aligned with a doctor's name, but we set targets for our various quality goals. We do this once a year. So this year we had a diabetes composite measure, a pediatric composite measure, a preventive services composite, hypertension measure, and a pneumococcal vaccination composite. And we send these reports out and let every single doctor see how every other doctor in the practice is doing. We send them out by clinic. We send them to the staff. And again, for our employed physicians, some of these metrics are often used as a part of the contracting for their incentives, but it's also used by the staff for what we call their Excel performance incentives that they receive if their clinic does particularly well. So it aligns both the staff and the physicians in those clinics where both are held accountable for quality of care. We decided to go completely transparent with our patient satisfaction data. There are a few, there's an increasing number of centers around the country now that are doing that. This is one of our physicians. I picked on him because he's highly regarded and has great patient satisfaction scores. But remember that as a part of the value modifier, patient satisfaction is one of the required metrics. We're required to pay for it, so we pay Press Ganey to do our PQRS CAP survey. But we publicly report the data. So we put it on our website. If you go to Find a Doc, I'm not showing you anything that's not in the public domain, findadoc.umedicine.com. This is a particular family physician. And if you clicked on 23 comments, you can actually receive the comments that the patients made about this particular physician. We post good comments and we post bad comments. The only ones we redact are if they have profanity, if they have HIPAA, or if there's any specific liability issue known. But we provide all of these comments in the public domain. And amazingly, it's really, not surprisingly, physicians really care about what's getting posted to the website, particularly the comments. And so we think it's been very helpful in terms of physician communication, doctor rating, and other things because people are really paying attention to their interactions with the patients. So we've been very transparent. I had to throw in one public health slide since I'm a professor in the College of Public Health. I think as we move to a value-based payment program that's focused on keeping a population of patients healthy, again, in our organization, I think in many organizations, it's starting to change the conversation about what healthcare actually looks like. We all know how to take care of patients when they get sick. We know what to do when they come into our clinics to be seen for acute care visits. We do that stuff routinely. What we haven't done well, though, is think about ways to keep patients out of the clinic. So the example that I use in our practice that makes some of the doctors really nervous and somewhat uncomfortable is I know in our practice, we have a large pediatric practice. We have kids with asthma that, guess what, they come to the emergency department and they get admitted to the hospital with exacerbations. Now, asthma, maybe you can't prevent all of those admissions, but it's an ambulatory sensitive condition. If we can do better in ambulatory care. So I've looked at all of the quality metrics around asthma care. Our doctors use controller medications. They're prescribing the right drugs. But the kids are still coming into the emergency room with exacerbations. And so what I say to our group that makes them nervous sometimes is that maybe we should go into their home and if they need, if they're roaches or other things, let's hire an exterminator because it's cheaper. It's cheaper to hire an exterminator to kill the roaches in their home than it is to pay a hospital for an ED visit or a hospitalization. We need to start focusing on some of these socioeconomic factors, these social determinants that are driving health for the patients that we're being held accountable for. So we're focusing first on a Medicaid population where we have a large number of patients that are assigned to us, and we receive data files from the state Medicaid agency that lets us know who's going to the ER, who's being hospitalized, and we're starting to focus on that population of patients. But it's changing the way we think about what healthcare looks like. Maybe they can't afford their medications, and we need to figure out how to get them for them. Maybe they need transportation so they can come to the clinic and not just ride the bus to the emergency room, or heaven forbid, call an ambulance. We're not trying to fix the world here. In some cases, we know are complex cancer patients or HIV patients that have complex or opportunistic disease. We're not going to fix those. We're trying to fix those that are ambulatory that maybe, if we did a better job, we could keep them out. And again, this is a slide from the CDC that simply highlights if you really want to have the biggest impact on the health of a population, you focus on these things at the bottom: poverty, education, housing, inequality, where they live, transportation, meds, access to that. Because we do these things in the United States, I think pretty good, clinical interventions and other things. So I'll end with this slide, one that we've been talking about here a lot on our campus. It's the 4 Actions Framework for Accountable Care. We're talking to our practices, our staff, and others about eliminating unnecessary redundant testing, avoidable hospital readmissions. We've gone completely electronic with our documentation. Big focus in the hospital setting on reducing hospital-acquired infections that often result in readmissions. Trying to reduce some of the fragmentation to care. One of the things that happens if you reduce overall hospital readmissions is you actually reduce overall hospital admissions. We're trying to focus on health maintenance. We've built all sorts of decision support into our EMR now. We're using care managers to contact patients who have gaps in care. We've gone to text messaging and secure messaging for patient appointments and other things to make sure that patients come in for appointments. Obviously, been focusing on chronic disease management, particularly identifying that group of patients who have complex needs, getting them engaged, but really thinking about how we get into the homes, into their healthcare setting to keep them healthy, and working together using our portal and other access networks. So those are the things we're talking about. It's the ways that we're trying to prepare. Look forward to the questions that you may have and your comments, because we're still learning. But one thing I'm reasonably sure of is that this move from volume to value-based payment is not going to go away. It's very bipartisan, and I think we all need to start preparing for different ways to deliver health care. So, John, I'll stop at this point and be happy to answer any questions.
Great. Thank you, Dr. Bratzler. That was a great presentation. At this time, we'll take a few questions presented. Please enter any questions in the chat box. So as we wait for those questions, Dr. Bratzler, I have one for you. You mentioned patient portals as being a way to engage patients, and certainly, in an environment where good health depends a lot on the patient, what kinds of activities or what kinds of things are you using your patient portal to engage patients with?
Yeah, so that's a good question. So we have a brand new patient portal, so we're going through some learning pains and growing pains with a patient portal. We're in the process of rolling out. We're trying to make secure messaging our default mechanism of communicating with patients, because we think it's much more efficient. We'll spend far less time on the telephone. And some of our practices, particularly in family medicine, have made basically told the patients, we actually don't want you to call unless it's an emergency, that, we want you to use secure messaging through the portal to contact us, and we will then answer. It allows us to answer questions in bulk at times when it's convenient, not somebody dropping everything to answer the phone. Obviously, we use the phone when we're notifying patients of critical lab results or other things, but we're trying to use it for messaging. And that's how we push out test results, and we want to broadly start using the portal to push out test results, particularly those that are routine, that patients can get to as quickly as possible. Patients can actually request appointments, refills through the portal. And the next step that we want to do is start capturing some of the information that takes a lot of time at the time of clinic check-in and other things through the portal, to allow patients to upload some of their health information, some of the screening questionnaires that we routinely do. We want to start getting those so that they're online, so that when possible, patients complete them. It only works for me if that then populates structured data in the electronic medical record. But those are some of the things we want to use our portal for.
Great, thank you. I have one more question too, while we wait for some questions to come in. And that goes back to your point about attributing patients to the reports that you've looked at. So you had a lot of patients that were attributed to your group as a primary care provider who actually saw specialists. And I'm wondering again, how do you communicate with the specialists that are either in your local region or even part of your group? Do you leverage some of the capabilities of your EHR to do transparent communications or transparent handoffs of data, that type of thing?
Yeah, so our practice is very specialty dominated. Actually, family medicine or primary care is actually a relatively small part of our big practice. We're an academic center. So when we got our QIn-QIO report, one of the first things we noticed was that 20% of the patients attributed to our practice see only our specialty physicians, and by definition, if they're seeing a primary care physician anywhere, they should be attributed to that primary care physician. So that just told us that there were 20% of the patients who weren't being seen by primary care physicians. So we started looking at what are the specialties that account for most of those patients that don't have primary care physicians, because we thought it would be things like nephrology, patients on dialysis that never see a primary care physician anymore. And we were surprised that the number one specialty was neurology. So we think it's because of Parkinson's patients, dementia, stroke patients, or others who have kind of moved into neurology care and kind of quit seeing their primary care physician for whatever reason. So neurology was number one. So we've shared that data. We're in the process. We just got our mid-year QRUR report, and we're in the process of now analyzing that data file to start figuring out how we notify the practitioners that here's a patient and you may or may not be aware of it, but they're not seeing a primary care physician anymore, so you need to be attentive to their primary care needs. I get the pleasure of meeting with our management group, which is all of the department chairs and some of the practitioners on a routine basis. And also we have all of our clinic managers come together once a month where we meet and go over these things. And we're trying to highlight that just because you're in a specialty practice doesn't mean you can ignore some of these other important health maintenance things that patients need. Our state was number one in the country for shortage of primary care physicians based on a study done published in the New England Journal a few years ago. We don't have nearly enough primary care physicians. So we're trying to figure out how to use our care management teams and others to ensure that these patients are receiving needed services that they need, and making sure that the primary care physicians, the specialty physicians, if they're taking care of one of these patients, is getting all care needed. So neurology, I mentioned, is number one. A couple of other areas, heart disease, patients who have chronic heart failure, other things. They need to quit seeing their primary care physician and just see a cardiologist. For patients with advanced chronic obstructive pulmonary disease who see pulmonology and don't return to see their primary care physician anymore, or have trouble getting in. Frankly, access is a challenge in Oklahoma. So we're trying to make sure they're aware of it, that they know. I saw one question that came up about how we organize our team within the practice to achieve our quality goals. I'm really lucky here. I have resources, so I do have a few nurses that are assigned to quality. I have a weekly meeting with our entire team that includes some of our EMR support staff. We have a data analytics team. It's not really large, but a few people that focus on all of these data files, so meaningful use files, or PQRS metrics, all of our quality goals that we establish each year, and clinical operations, so our operations folks, and then most recently we started a small population health department, and I'm the director of that department. So we come together once a week, every single week, to go over all of the issues. We spent a ton of time cleaning up the electronic medical record, building in decision support, cleaning up data, getting data out of text fields into structured fields, so we can really start assessing our performance. So I recognize I'm in a big practice and I have that luxury. You may not have that in small practices, but many of the QIO, QINs, or some of the work that the National Office, the Office of the National Coordinator for Health Information Technology, some of the regional support centers that they've had can help even smaller practices work on some of these types of activities to drive quality.
Okay, please send questions to all participants in the chat. Do we have any more questions? I have one more, Dr. Bratzler, for you. You mentioned the QIUR report as being very valuable, and yet a lot of physicians don't use them. What do you think the issues are around that? Is it they don't know they exist, or they're difficult to get?
Yeah, I would say both of those things. So I think I was surprised, again, I was at an internal medicine conference and was talking about use of the QRUR, and a lot of people had never heard of it, didn't even know it existed. And then the CMS portal isn't necessarily the easiest place to use and get access to, and I always forget my password and have to renew it frequently. So I don't think they're always that easy. Again, I know some of the QIO, QIMs are working with practices to make sure they know how to access those reports. But by law, by 2017, CMS has to enroll in the value modifier program all practicing physicians. So that means there should be a report card for virtually every practice. Like I say, the past couple of years, they were only out there if you were a very large practice, but as you saw from the number of dots on the slides I showed you, the number of practices now that have reports has become very large. And I strongly encourage you to look at it because it provides data on cost of care. For instance, it provides you cost data, your total cost of care for COPD, diabetes, heart disease, and I'm forgetting there's one other category, patients as compared to the national mean. It gives you your Medicare spending per beneficiary compared to the national mean. It provides you information about where you're spending money, where you're above or below the national average. So for our particular practice, our laboratory costs were relatively high, our use of certain ambulatory procedures were relatively high, but our E&M coding and other things tended to be relatively low as compared to other practices. So it lets you kind of see where your practice is compared to the national average. But what it's done for us is it's let us start thinking about how we start focusing our efforts to drive improvements in quality. And again, I'm fairly convinced that these are the things that are going to impact our payment going forward. So we need to figure out how to be more efficient, and we need to make sure that we're delivering high quality care whenever possible. So we use the report extensively and the data files that come with it.
Thank you. So we have a few more questions. Do you know if macro will expand to Medicaid?
Will it expand to Medicaid? There's no requirements in the law to expand to Medicaid that I'm aware of. I think it's possible that some states may put into place a variety of value-based payment mechanisms. I know there are a number of demonstrations happening in various states around the country, but MACRA, I don't believe, it's been a while since I've read the bill, but I don't think it included any language about Medicaid.
Thank you. Do you know if the QRUR is available to practices with less than 10 providers?
I don't know if it is yet, but I think it will be for 2017. Because CMS is required to provide that report card. It's actually spelled out in the Affordable Care Act that they must provide a report card that summarizes cost of care and quality of care for all practitioners. So it's not out there yet. I think it will be. I don't know the exact dates. The QRUR typically, so we received our 2014 QRUR report in October of 2015. In October of this year, I would expect to see the QRUR for 2015 data. So there's always about a year lag when you get the final report. We just got the mid-year report, though, for the first half of 2015.
Okay, so we have another question, too. Will MACRA or MIPS affect physicians within the acute care setting?
MACRA applies to physician payment in the ambulatory setting, but the payment penalties or incentives apply to all of your billing. So if you're doing ambulatory care, it could potentially impact your entire Medicare book of business. So as an example, in the PQRS program, the value modifiers, you don't report PQRS measures out of your practice, you'll see a 2% cut in your Medicare payment across everything that you do that you get paid by Medicare. So inpatient, outpatient. So for our group, participation in PQRS, we didn't do it for the incentive. We did it primarily to avoid the penalties because the penalties were far, far greater than any incentive payment that we ever got when you could get incentive payments for PQRS. And the same is true of the value modifier. It's a 4% automatic cut if you're not reporting your PQRS measures, and that's to your entire Medicare book of business. But the MACRA, the actual law itself applies to ambulatory practice.
So we have one more final question. I see a lot of less than high quality care being provided at urgent care centers. Will they need to abide by NIPS?
It will depend on whether or not they are billing Medicare. So if they're doing it as an ambulatory practice and billing Medicare, then I think they could potentially be subject to the payment programs. Unless somebody may know billing better than I do about urgent care. I don't know if they have a special category for Medicare billing. If you're doing ambulatory billing under Medicare, then it would apply to you. The other thing that I found interesting, I don't know if you saw the paper by came out of California just recently, looking at telemedicine and the quality of care delivered via telemedicine, and I think a lot of us have had quite a bit of concern about some of the performance on telemedicine encounters. Again, if they're not billing Medicare, it's not going to affect them. It only affects you if you're billing Medicare. But I think urgent care, telemedicine, and other systems of care that are being delivered, I think there needs to be close scrutiny on quality of care.
Well, great. Again, thank you, Dr. Bratzler. That was a great discussion. I have a few last-minute announcements before we end today's call. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with a link to the evaluation, as well as a link to the event page on our website. The PowerPoint presentation is already posted on the event webpage. Within the next few business days, a recording and transcript of this webinar will also be added. Thank you again for attending, and have a great day.